Good morning and afternoon from everyone from East Coast, West Coast, and in between. And I think we have some good evenings for some of our friends who are in different countries. So thanks so much for joining. We're getting everyone entered into the Zoom room. So we'll just take another second to have folks join. Thank you so much. I'm Andy Dwyer with University of Colorado Cancer Center, the School of Public Health. Working with Fight CRC for the Early Age Onset Work Group. So I apologize, my camera is experiencing some technical difficulties, but believe me, this is a much better picture of myself pre-COVID-19. So, and when I mean 19, I mean 19 pounds. So just like everyone else, definitely struggling with making sure to be active. So we're gonna go ahead and get started in just a sec. While we're getting people on, I'd like to introduce Reese Garcia and Elsa Weltzing, who are going to be helping provide technical assistance and support for today. Reese, while we're getting folks on, would you like to say a few words about the Zoom platform and any housekeeping around how to manage today?
Absolutely. Hi, everyone. Thank you for joining us today. We will be having discussions throughout the webinar today. So when the time comes, you have a feature to raise your hand. And that will allow us to take you off mute so we can chat directly with you. If you have any questions or comments throughout the presentations, please feel free to use the Q&A feature, which is also along the bottom bar of your Zoom screen. Again, if you have anything that pops up, we will be addressing them real time. And we look forward to having you join us for our first webinar today.
Okay, great. I'm going to go ahead and kick us off. So everyone, again, welcome on behalf of the International Work Group and Consortium for Early Age Onset, convening with leadership from Dr. Jose Perea and Fight CRC. We're delighted to launch the inaugural session of our work group series connected to really discussant topic discussion, thinking about research collaborations, how we dig further into really connecting the work from an international theme around the work. And Dr. Perea is going to talk a little bit about the initiation of this group as well. So I'm Andy, and I'm really excited to have all of you join us for today. I know we've had a series of meetings beginning in 2019, and there was a lot of formative work done by Dr. Tom Weber's team, the National Colorectal Roundtable, and others that we continue to build off of and continue to hope to collaborate in this work. But the series that we're launching today is really dedicated to every other month where we're digging in for an hour or two to really around dedicated research topics that we think will help really bolster early age onset collaboration and consortium building as noted, as we really think about common trends as well as really looking at differences in the population related to research initiatives. So I am really excited that we're ready to go. Next, can we talk about the agenda real quick here, Reese, today? I want to also just give a huge nod to Dr. Dennis Onen, who was a leader within the field and a driving force for Fight CRC to engage in early age onset work. We did lose Dennis just a couple of short weeks ago, and his memorial service will be in October. So I wanted to just again give another another nice mention and honor Dennis for the great work that's really driving us today, and his legacy will live on. We're very excited to move forward where we're going to spend the next 2 hours. And I think that what you're seeing in front of you now is a structure that we'll use for these meetings moving ahead. We will have a dedicated topic in discussion each time. And today we're going to be hearing from Andriana and our team, and Dr. Jose Perea will give a good formal introduction. But we're really going to be speaking to the health disparities and CRC disparities within the early age onset and unraveling some themes and some data and research that's driving this work. We're going to hear from Dr. Perea talking about addressing specific questions. We're going to address some of the questions that have come up prior to today's presentation from all of you. And during the presentation, Andriana is going to be speaking to some of those, as well as have some time for discussion with Dr. Perea. And then we're going to open it up for a large discussion with the group. But what you'll see in the format moving ahead is that we will have a topic and a subject matter expert. We will have a key discussant. We will offer opportunities for questions ahead. So our presenter and key panelists we'll have a time to really think through those questions and integrate, and then a time for discussion. And then in each session, we are also planning an overview of current research papers, and then funding potential that are moving forward. So what you're seeing in front of you today is really the format that we'll use. There has been a survey that has been circulated to talk about what are the key and priority areas that we want to address in terms of this workshop style. And again, just to reiterate, the idea is to really dig into some of these topics, these pieces, thinking about the collaborations, and then Dr. Perea will talk a bit about, even for this year and this summer, coming forward, an opportunity for us to really convene again in Europe, in Madrid, which was postponed from last year given the pandemic, but we're really thinking about connecting in person as well. So this is the format we'll be using. We're really excited about this moving forward. So before we dig into today, I also want to give remembrance to Chadwick Boseman. And I know that many of us are, and the topic couldn't be more relevant today, but I really think around patient care, stigma-related issues, as well as what are we doing to really address early age onset from a variety of aspects. This is something that Fight CRC is going to be working on, an editorial. We are going to be asking our work group members, all of you, to sign on with us. And hopefully this piece will be posted in some of the larger media conglomerate teams. Moving ahead, we have a couple of advocates that are helping also drive this work. So there will be more information about this coming in the next 24 hours. And if you're willing and interested to sign on with us, we would be delighted to have names and institutions from all over the globe to really help back, not just the clinical and the awareness component, but just digging in to say we really need to know more about the why and the research component. So more to come on that, but just a primer. And again, just really excited to launch us today. I'm going to actually hand it over to my partner in crime, Dr. Jose Perea, to talk a little bit about the why we're hosting this. We'll move into the schedule and logistics, and I will have the opportunity to also introduce a new team member from Fight CRC. But before we do that, Jose, I would love some opening words about where we're moving.
Okay, thank you very much, Andy. So, and of course, thank you very much for all the people that are attending this first webinar, and hopefully the next that we are going to host. So the idea of this webinar series have been born for many reasons. I think among others are, of course, the importance of that early onset colorectal cancer is acquiring worldwide as a health problem, and of course the need that we should solve it. Secondly, and in parallel, the growing number of studies and publications related to the different aspects involved. I think also it is one of the reasons that we are developing these webinars. Therefore, and also to cover the existing gap of time between the Early Onset Colorectal Cancer International Symposium that we organize every year, we think that it is essential to also periodically every year just to update the knowledge about early onset colorectal cancer, and at the same time to create a forum, a consortium, where everyone who is involved in the problem of early onset colorectal cancer can exchange all kinds of ideas, projects, and experiences. All of this, of course, also from an international perspective. So in summary, we think that this webinar should not be only, but also an active consortium about early onset colorectal cancer. And we hope that we start developing that from today. So Reese, when you want.
Great, thank you, Jose. And I'll introduce Elsa and then we'll have Reese just share a few other pieces if there are any other logistics. But I am honored to also introduce Elsa Weltzine, who's joined the Fight CRC team and who will be helping lead out a number of the initiatives moving forward related to the work groups with Fight CRC, which really do hinge on medical, scientific, and research experts convening to really drive the research with partners like Jose and others, and really thinking also about those policy aspects on the other side of the Fight CRC house. But Elsa is really going to help really move this forward. And I've worked with Elsa for the past, I don't know, Elsa, what is it, 3 years now? 2 years?
I think we're at 2 years.
2 years in Colorado for our statewide screening initiatives. And she is a great leader, a young professional who's growing tremendously, and we're very excited about her joining with her expertise in now colorectal cancer evaluation, research expertise, and also very skilled in terms of biostats and epi. So excited to have Elsa on board, and Reese will continue to walk with us through the research work with Fight CRC. Reese has also been amazing through this work, but our work is really growing substantially in this area. So we're really excited to have some continued support. So Elsa, I'd love to have you just say a few words and give a little more background about yourself. And then we will continue on with our agenda.
Sure. Thanks, Andy. I'm thrilled to be joining the Fight CRC team. I've had the opportunity to connect with a few of you in the work group through my work at the university with Andy on our statewide screening program for CRC, lung, and family history screening. And so I was thrilled at the opportunity to join the Fight CRC team to really focus on moving forward the efforts of each of the work groups. And early age onset is an area of CRC that I really care passionately about. So I'm looking forward to learning a lot from each of you and getting the chance to talk with many of you further.
All right, awesome. Thank you so much. And Reese, anything further before we have Dr. Holvety and Dr. Perea joining us for our discussion?
Just as a reminder, please use the raise your hand feature when we get into the discussion, as well as the chat and Q&A function to keep up with the conversation and ask any questions to our presenters. Okay,
great. So in front of you, you do see the agenda. Again, we are spending the time today in some discussion, particularly between 1 and 1:30. So that's a period of time that we will ask for that hand raising, the chat. But during any time in the presentation, if you do have questions or things that are coming up for you, we will be watching and monitoring and addressing those with our two subject matter experts. So with that, Jose, I will turn it over for a deeper introduction from you about your work, as well as Andriana as well. And a huge thank you to both of you for joining today. I know we had a number of people who couldn't join real time who noted that they will be waiting for the actual recording as well. So I think we have over 40 people on today, or 40-ish on, and probably equal number who responded that they are really excited about hearing the replay of this work today. So Jose, I will pass it over to you.
Sure. Thank you, Anne. And of course, it is an honor to be here and be part of this great effort. So when I have to introduce someone in this type of event, and having Google, PubMed, and all kinds of online possibilities to see the curriculum, to a professional career of the person, I prefer to do it in a more personal way, especially when you already know that person. So currently, I think, in my opinion, Vanderbilt University Medical Center in Nashville is completely fortunate to have Andriana Holowatir. She is one of the researchers who has published, I think, the most in recent months about different types of early onset gastrointestinal cancers, especially about early onset colorectal cancer. And in my opinion, of course, but I think it's true, with an parallel effort, dedication, and enthusiasm. So, of course, thanks to our current collaboration, I can confirm all of this for sure. And she also has a special dedication to disparities related with sex, races, ethnicities, among others. And as I think will be demonstrated in the presentation. So that is why we thought, when we organized this webinar, she was the complete correct person to develop that. And when you want, Andriana.
Thanks, Jose. Let me share my screen, if that's all right, and we can get started. Thank you for that lovely introduction. I'm thrilled to be here today, kind of discussing a bit about early onset colorectal cancer disparities, really in a global fashion, to really understand and tease apart some of the breadth of work going on in this space worldwide. And so I think Andy mentioned it, but can't go without saying or reporting about the tragic news regarding the death of Chadwick Boseman from early onset colorectal cancer. I think it just fortifies our mission. It strengthens our resolve to continue working to understand the etiologies underlying this epidemic. And it also emphasizes the real great work of advocacy organizations like Fight CRC, as well as all of the early onset cancer patients and survivors and thrivers that dedicate a great amount of time to advocacy for this disease space. So just to give you a brief background of my talk today, given that I'm talking to many colleagues and experts in the field, I'll be brief in my background on the early onset colorectal cancer burden. And the majority of my talk is really going to focus on giving a global overview into the breadth of early onset colorectal cancer disparities in patterns and outcomes, centrally focused on disparities by race and ethnicity, sex, and geography, each of which I could spend an hour talking about. So the purpose of this talk is really to give a high-level overview and understand some of the different facets that contribute to these disparities and ongoing work to try and mitigate them. And given that although much of this work has been done in the United States, I really want to acknowledge the burden of early onset colorectal cancer rising worldwide. And so I'll be framing my talk today with 4 different continents, with 4 representative countries from each of those continents to discuss a bit about the early onset CRC burden across the globe. And I'll close out with some future early onset colorectal cancer disparities research and directions, kind of where the field is moving, where my teamwork is going, and where we'd love to collaborate in further. And so this is a statistic that unfortunately many of us know, this harrowing information, that colorectal cancer is the 4th most commonly diagnosed cancer among individuals aged 20 to 49 years worldwide. And it accounts for just over 6% of all new cases of cancer diagnosed among young people annually. Similarly, many people have seen this figure looking at colorectal cancer incidence rates in the United States over time, where in contrast to the middle panel and the panel on the right, where we see the burden of colorectal cancer decreasing among men and women aged 50 years and older, we see this gradual uptick with a 1.5% annual increase in early onset colorectal cancer in patients younger than age 50 years. Reasons for this are largely unknown, as you've often heard and we'll hear in my talk as well. But importantly, this trend is paralleled across several countries and continents, notwithstanding the countries listed here as well. So this truly is a global epidemic and something we're working really hard to address. So evidence is emerging to really suggest that early onset colorectal cancer is a distinct disease entity, both clinical pathologically in terms of prognostic outcomes, as well as biologically and molecularly. And evidence is showing that colorectal cancers diagnosed in young patients tend to behave more aggressively compared with late onset cases. Indeed, young patients have been shown to have more commonly be diagnosed with signet ring cell carcinoma and other adverse histological features that are associated at times with poor prognostic outcomes. And patients with early onset disease tend to be more likely to present with or develop metastatic disease versus late onset cases. And with these 2 pieces of information in mind, it comes as no surprise then that in study of patients diagnosed with metastatic colorectal cancer, you really see this shift with the younger age associated with poor overall and progression-free survival, as well as the older population. This is reflected in the top 2 panels of this graph, where you can see the overall the relative hazard of death is being plotted by age at diagnosis for overall and progression-free survival, and seeing this uptick and trend upwards towards The left side of the graph for younger age of onset is indicative of these poor prognostic outcomes in young patients. And we also see in several single institution studies that there's a disproportionate burden of colorectal cancer recurrence among young patients, up to about 45% of some young patients in institutional cohorts end up presenting with disease recurrence. Furthermore, while several individual and single institution studies have performed biological phenotyping of early onset colorectal cancer for one individual molecular level to show distinct features associated with early onset disease compared with late onset cases, we recently took a multi-omics approach to this question and integrated multiple molecular layers by combining tumor transcriptomic data paired with plasma metabolomic, proteomic, and serum-based biomarkers of inflammation to integrate these independent multiple molecular features and really discern a distinct hallmark or phenotype of disease. And in doing so, we identified imbalanced redox status via glutathione metabolism and oxidative stress response primarily as a distinct hallmark of early onset sporadic colorectal cancer, which was not observed in late onset cases. This is particularly timely and interesting given that obesity is a major factor in oxidative stress. And recent work has shown that obesity is indeed a risk factor for early onset colorectal cancer among women, and may also reflect differences in health behaviors and changes in diet over time as well. I want to draw attention to the fact that we performed this study in a cohort of German patients where just about 15% of cases were diagnosed with early onset disease. And I draw attention to that because while many studies have evaluated early onset colorectal cancer patients as a group, in the context of this global problem, as well as across different population subgroups among young patients, it's really important to decipher and discern whether these patterns that we observe in young German patients will persist in different environments, in different population groups, such as the United States, given differences in dietary patterns, geographical regions, access to care, etc. And I think that really illuminates the need for a focus on early onset colorectal cancer disparities, which is obviously the focus of my talk today. So just to kind of give a little bit of a framework in identifying and addressing social determinants and how to advance cancer health equity, it's important to consider that determinants of individual level cancer risk and survival are a compilation of biological and genetic factors, environmental, health behaviors, healthcare, as well as social structure factors. And indeed, health disparities stem from social structured factors, as illustrated in this complex but really elegant figure. So starting at the top over here where they feature structural inequities and social injustice, really for the United States based on its history and narrative on race and considering race a social construct instead of a biological construct, and some of the systemic racism that has led to different disparities amidst populations and systemically disadvantaging certain groups. But these social determinants on a population level also interact with institutional environments as they're embedded into social structure overall. And in turn, these also have an influence on individual level living environments, or what's considered social needs here. So if you consider social determinants at the population level, social needs really lie at the individual level, where economic environments in terms of socioeconomic status, physical environment in terms of health behaviors and patterns, the service environment relevant to healthcare access, and the social environment relative to individual level support. And this is critical because it's really important to know that individual factors and the level of social needs are not enough to understand disparities by socioeconomic status in cancer. You really need to take an integrated approach and understand both the individual and community level factors that are ultimately leading to these inequities due to varying conditions. And these diverse social determinants of health over here then cause influence on the bottom half of this figure below, where you see health disparities arise in, for example, cancer due to these different consequences. And they influence risk factors such that different population subgroups have different risks across different cancer subtypes. They may lend to different biomarkers being diagnostic or predictive across population subgroups, lead to differences in everything from screening and detection all the way through cancer survivorship, ultimately potentially influencing patient outcomes. And really an important point to carry through my talk is that these social, economic, and geographic disparities cut across multiple populations, characteristics. So you can't talk about race without potentially considering sex. And these two also impact geography, as you'll see. And so you can really see that all these factors are interrelated quite a bit. And it's really a complicated problem to really be able to adequately and properly address these social determinants, not just on an individual level, but on a population level, to be able to mitigate disparities and advance cancer health equity overall. So as we mentioned probably a few times, early onset colorectal cancer is indeed a global epidemic. And while much of the data that I'll present to you today derives from the United States, I really wanted to take an opportunity to discuss disparities on a global level. And so after presenting some data on early onset colorectal cancer patterns and outcomes in the United States, I'll actually shift to discuss some of our ongoing work with colleagues in Zaria, Nigeria, to unravel the disease burden there. And shift up to take a look at a study of ours in Spain, and finally briefly end with some initial evidence coming out of our collaborations in Makassar, Indonesia. But beginning with the United States, I just want to highlight this figure that shows the colorectal cancer incidence for individuals across all age groups by both sex and race, because you can really illustrate the stark differences in colorectal cancer incidence by these population subgroups and emphasize the importance of understanding cancer health disparities. You can see here by the figure with non-Hispanic Blacks represented in the red bar and American Indians and Alaskan Natives represented in the purple bar, that while grouped as both sexes, but also separated or stratified for both men and women, we see colorectal cancer incidence rates are consistently highest in non-Hispanic Blacks, followed closely by Alaskan Natives. And indeed, additional study has revealed that the proportion of individuals specifically with early onset colorectal cancer is nearly twofold higher among non-white races and ethnicities in the United States, particularly the Latino population, the non-Hispanic Black population, as well as the Asian and Pacific Islander population. So this really further drives the need to understand what differences may be going on in early onset colorectal cancer etiology and outcomes. Indeed, this work has, I think, crossed all of our desks in the study of individuals in the United States that demonstrated that compared to individuals born circa 1990, similarly aged counterparts, or I'm sorry, 1950, similarly aged counterparts born in 1990 have a twofold risk of colon cancer and a full fourfold risk of rectal cancer. And although young patients have an increased likelihood to have a familial history of disease compared to individuals diagnosed at age 50 years and older, it's really important to note that 5 out of every 6 early onset colorectal cancer patients don't carry a germline mutation associated with cancer predisposition, really lending to them being diagnosed with sporadic colorectal cancer. And this is pretty alarming given that etiology is underlying this sharp increase over time in sporadic colorectal cancer incidence among young individuals remains unexplained. And this figure here in this data is really comprised across cancer registries in the United States. So it's combined, representing multiple races and ethnicities within this population. And so I want to one of the things I want to emphasize is that while many studies have compared early onset to late onset colorectal cancer, there's a lot of heterogeneity within the population of young patients diagnosed with colorectal cancer. So we led a population-based cohort study of about 5,000 individuals diagnosed with colorectal cancer between ages 15 to 39 years. So we were specifically focused on the adolescent and young adult population in this study, and taking a look at patterns of different clinical and demographic features by age of disease onset. And so you're seeing some of that data presented here, where across different 5-year age groups, and taking a look at the racial and ethnic breakdown and proportions of each age group by race and ethnicity. What I want to draw your attention to amidst all of these numbers is the Hispanic population, as we reported that we saw this shift. And while Hispanic patients accounted for 1/5 of cases diagnosed at age 35 to 39 years, they accounted for nearly 30% of cases diagnosed between 15 to 19-year-olds. And this is a smaller sample size within this age group, but the trend pretty elegantly persists as you decrease in age. We also noticed a shift in right-sided tumors associated with decreasing age, which has been reported quite a bit throughout the literature. But by just considering the Hispanic population, given the data that was available to us in SEER, I think it's really important to dive within a population and also consider the context of disparities within subpopulations that may have different incidence and disease patterns of early onset compared to non-Hispanic whites. So in this case, I just wanted to carry forward that finding that we saw that Hispanic patients tended to be diagnosed at younger ages, with a study performed by Stern and colleagues that really identified and defined colorectal cancer disparities among Latino subpopulations by country of origin. So this data source was the California Cancer Registry over about a 15-year study period, and they had additional information on Latino subpopulations by country of origin. And one of the things to note before even dissecting some of this data is the fact that patterns are showing that incidence rates for colorectal cancer in US Latinos are actually generally higher than those reported for most Latin American countries, really emphasizing an understanding of the social construct and the environment in both the individual and community level factors that may be related to these different trends. But taking a look at the data here, specifically looking at the proportion of each population with early onset disease, what I draw your attention to is that 20% of Mexicans diagnosed with colorectal cancer in California were actually diagnosed with early onset disease. Similarly, 20% of the Central and South American population was diagnosed with early onset disease. This is in sharp contrast to the fact that even among almost 600 Cubans, only 4% of that population, that subpopulation, was diagnosed with early onset disease. And I think this nicely is framed in the context of the non-Hispanic white group presented here on the far right by the authors, where approximately 7% of the non-Hispanic white population diagnosed with colorectal cancer in this registry was diagnosed with early onset disease. So we really see distinct trends and patterns within the population of early onset cases and within certain population subgroups even that warrants further investigation. So kind of some conclusions drawn from this study. As I mentioned, younger age at diagnosis is associated with this higher propensity for right-sided tumors. That's interesting in the context that a study recently published in gastroenterology showed tumor site-specific risk factor profiles, illustrated nicely in this figure, where you can see everything from dietary factors that may contribute to risk factors for rectal cancer versus seeing older age and female sex be risk factors for right-sided colorectal cancer. I do think this figure lends for me to give the disclaimer that it's also really important to not conflate appendiceal cancer with right-sided colon cancers within these data sets, in addition to looking for trends across the colon and rectum, given the evidence is beginning to accumulate that appendiceal cancer is indeed a distinct feature by clinical and molecular features. And so to really get at a better understanding of early onset colorectal cancer patterns, that distinction needs to be made between appendiceal cancer and other right-sided, like sequel tumors. But nonetheless, off my soapbox briefly, we also noted that Hispanics were diagnosed with early onset colorectal cancer at younger ages versus whites. And that really leads to the question, are there differences in cancer determinants among the Latino population of patients with early onset disease? To kind of give you a bit of perspective about that, data from the US Census really nicely is reflected in this pie chart that shows the diversity of the Hispanic ethnicities of individuals residing in the United States, really kind of illustrating why this would be an important factor to further investigate. Altogether, emphasizing again my point, the need for studies even within early onset CRC population subgroups, in addition to looking across early onset population subgroups as well.
Andriana, we have a couple of questions, and I think maybe since we're at this point, are you cool if I ask you just a couple things that have come up, because I think we're here. One question from, I think, Samir Gupta and then Whitney Jones. Going back, well, actually, we'll stay here for a minute. Were the STEM data for Mexican Californians stratified by time since immigration/generation?
Oh, in the Stern study.
In the Stern study.
Yeah, so they were not. In reading this paper, I did not include the data that actually looks at their immigrant status, whether they were foreign born or United States born. So I know they looked at that as a characteristic. I'll disclaim that the emphasis of the study was not on early onset. I saw these proportions and was really intrigued. The overall scope of that paper is to look at disparities in incidence patterns among all Latino subpopulations for patients of all ages. So some of their data is broken down by age, specific incidence rates, and then just in the whole population.
Okay, great. And then back to one of the earlier slides, specifically, the question is not the rapid increase recently, 2000 to current, seen primarily in Caucasians? Non-Hispanics are, quote unquote, closing the gap with African Americans. The 2001 paper was looking at 1990s data with a question there. So the question is in the chat. So Andriana, any thing that's coming up for you based on Dr. Jones' question?
Yeah, can you repeat the first part really quick? Sorry, I can't.
Yeah, and it's in the chat here too. And Whitney, I don't know if you want to come off mute, you're welcome to as well. So the question is about, in terms of looking at that increase, are we seeing that from 2000 to current? Is the driving population really Caucasians in terms of that increase?
I'll be happy to. Yeah, it was my understanding that, African Americans have had such a high rate of early age colorectal and rectal cancer for so long, and that a lot of this increase was in fact in the Caucasian non-Hispanic population. Rather, the African American population had been remaining relatively stable, and I put that in quotes, so that some of this dramatic increase was being seen in a new racial group. Thanks for asking.
The great question. I certainly agree with you on that point, that relative risk figure in particular, really that's being driven mostly by whites. You're right, that disproportionate disease burden in African Americans is really illuminating, given that while the increase of early onset colorectal cancer instances happen, racial and ethnic disparities have actually grown more pronounced over this time. So I think they're kind of two competing, maybe parallel yet distinct issues, but I'd agree with that. And probably one of the things I should comment on in terms of the Hispanic population with age is that Hispanics tend to have a lower median age in the general population across the United States to begin with, but it really emphasizes the changing age and racial ethnic landscape, given that Hispanics are actually anticipated to be about 30% of the US population by 2030. So I think those are all kind of just different factors playing into it, but I would agree that drive is largely being seen now in non-Hispanic whites, but the question of why these disparities continue to grow more pronounced, I think is one that remains important.
Okay, great. We have one more question, but I think we are going to be addressing some of the pieces about specific tumor types coming forward. So I think we'll go ahead and continue on. Thank you.
And I think that point that was just raised in the chat, I think is a good one, is that despite the overall size of the population being 560, there are only 24 patients here diagnosed under age 50 that account for that 4%. But this is really challenging data to ascertain. It's something that I will also disclaim. Individual SEER cancer registries have access, to my understanding, to some of these subpopulation data, that those are not available in larger scale data sets like SEER, to my knowledge. And so it just highlights the need to continue being able to discern subpopulations and countries of origin to be able to study this area. But moving on to, I think, shifting to some more of the focus on disparities in prognostic outcomes now among patients diagnosed with early onset colorectal cancer. We also led a study leveraging SEER data, which, for those of you who may not know, is accounts for about 28% of the United States population, and several SEER sites were selected to intentionally oversample particular racial and ethnic subgroups and other populations. But we undertook the study that examined just over 28,000 cases diagnosed between ages 20 to 49 with colorectal cancer over a 10-year study period. And the age and racial breakdown of this population is shown in Table 1, just to demonstrate the proportion of racial and ethnic groups compared to the proportion of non-Hispanic whites here. And really the main finding that arose from our study was that Blacks had a 35% to 51% higher hazard of death in colon and rectal cancers respectively compared with whites. And to elaborate a little bit more about that data in particular, the most striking finding to us was when we stratified survival data by both tumor site and stage. We found that the largest disparities in early onset CRC survival between whites and Blacks were actually among patients diagnosed with earlier stage disease. So what I'm representing here are adjusted survival curves for overall survival. And so these models were adjusted for age, sex, surgery, radiation therapy, as well as a county level metric for poverty. And we saw the largest disparities for early onset colorectal cancer patients diagnosed with colon cancer and stage 2 disease, and then for cases diagnosed with rectal tumors and stage 3 disease. And so just walking through this really quick to point out some additional interesting pieces of this is non-Hispanic whites are presented in this blue curve here, with non-Hispanic Blacks presented in yellow, and Hispanics presented in gray. And one of the striking things is, although studies report similar SES levels between Hispanics and non-Hispanic Blacks, the disparities that we noted in survival among young patients were really between whites and Blacks, and we didn't see pronounced disparities in survival between whites and Hispanic cases. So this really lends to some interesting questions and something similar, although a little bit of a changing landscape over here in rectal tumors. In addition to identifying racial and ethnic disparities in survival, one of the things that we also noted in our study was pretty consistent finding that early onset colorectal cancer survival is actually significantly worse among men versus women, where men had a 15 to 20% higher hazard of death in adjusted models for both colon and rectal tumors. And when you again tease this apart by stage and tumor site, one of the things that you really see here is the consistency across tumor sites, and that men have this increased hazard of death compared with women, particularly among late stage disease here, which we hypothesize could be attributable to potential biological, behavioral, and maybe community level factors, as you'll see shortly, but was really unexplained. Men do have a higher incidence of colorectal cancer compared with women, which is important to note here, but this finding was still really important in the disparities context. So really conclusions from this piece, as I mentioned, survival after early onset colorectal cancer diagnosis is significantly worse among Blacks versus whites, even among patients with early stage disease, which I think is a note that's been echoing and reverberating after the death of Chadwick Boseman. And I know this was a question that was asked prior to the webinar, and so I wanted to include this here. And these are just from our study, overall in cancer-specific survival months for young patients, stratified by tumor site and stage. And the real consistency that you see here is lower survival months for almost every single one of these stages by site, with the exception of stage 1 rectal cancers, that Black patients have lower survival months compared with whites or Hispanics. Similarly, data from the National Healthcare Disparities Report really illustrates the differences in access to care between these populations, not only at a poverty level where you see individuals with lower income have 89% worse access to care compared to individuals with higher income, but you see that both for Hispanics and Blacks, you see that from 1/3 to 2/3 of the population has worse access to care compared with whites, which could be a large driving factor in seeing these disparities in outcomes among young patients with disease. In addition, we saw these sex-specific disparities in survival as well. So it really lends to the need for further study to determine whether differences in tumor biology and or treatment are associated with these marked disparities in young patient outcomes. Andy, are there any questions, or can I keep moving forward? I figure maybe good to pause if there are questions from each piece.
There's one question right now. Has anyone examined as yet whether Blacks with early age onset are less likely to either be recommended for guideline concordant treatment or receive, participate, or comply with guideline concordant treatment?
Tim, I'm not familiar with that to my knowledge. I know a lot of work in Detroit has come out of looking at the patient-provider relationship in terms of disparities by race, but particularly in the early onset colorectal cancer population, I'm not familiar with any literature off the top of my head there. Although I think that would be very interesting to better discern what may be driving those differences.
Okay, great. And if anyone has any suggestions of papers or data in the chat, please feel free to add that as well. So I think we are ready to move ahead.
Sure. So in addition to seeing all of these racial, ethnic, and sex disparities in early onset colorectal cancer survival, we are really prompted and intrigued to profile potential geographic variations in early onset colorectal cancer mortality across the United States. And so to do this with a real multidisciplinary team, we leverage national mortality data from the CDC, which reports cause of death files for individuals across the contiguous United States. And so for both men and women in this initial study diagnosed with early onset disease whose cause of death was early onset colorectal cancer, we used 3 independent geospatial mapping approaches to take a conservative approach and identify regions of disproportionately high early onset colorectal cancer mortality, which I will momentarily show you. For sake of time, I won't go into at the moment the second half of the study, but briefly, we leveraged the CDC data, linked it with county level data from various nationwide surveys, and as well linked it with SEER data to really see if we can discern differences among patients diagnosed with colorectal cancer residing in what we call these hotspots versus patients living in non-hotspots. And so hotspots, as I mentioned, are these counties with high rates of early onset mortality among both men and women in this first study. And that map is now shown on the screen. And what I think you can immediately draw from this figure, noting that hotspot counties are identified in red, is that these counties are highly concentrated in the southern region of the United States. And it's in fact 92% of all hotspot counties for both men and women in the United States are located in the southern region of the United States. And this was, the South tends to have a higher burden of other chronic diseases and different health behavior patterns, as I'll briefly show. But I think this was a striking finding nonetheless. However, I've emphasized our previous finding in sex disparities in early onset CRC survival, and we were curious as to whether these patterns that we've noted here and mapped among men and women could potentially be masking differences by sex. And so we went again, and over a larger study period, albeit given censored data and limited cases, we specifically derived hotspots for female early onset colorectal cancer mortality, and the figure is shown here. Notably from this data, about 1 in every 16 counties are female early onset colorectal cancer hotspots. But in contrast to what I've just previously showed you, here you see a marked shift in the location of these hotspot counties, where now only 53% of these counties are located in the South. And you see this upward shift that about 47% of the counties for early onset colorectal cancer hotspots among women were located in the Midwest and Northeast regions of the United States. Further, lending to the intriguing question as to what may underlie sex-specific disparities in early onset colorectal cancer patterns. But kind of just showing you these figures side by side overall, just illuminating these geographic disparities in early onset outcomes. You can really see these persist across the United States. Nationwide studies overall have shown that colorectal cancer among all ages, rates of mortality are highest in the South and Appalachia region. So these analyses specific to young patients with this combined mapping approach somewhat reflect those patterns among patients of all ages. However, I haven't presented this, but just to note, individual and community level features in subsequent analyses when linked with the SEER data actually accounted for distinct variance patterns in early onset colorectal cancer survival by hotspots, essentially meaning that we took a look at what factors contribute and how much of the variance in survival they contribute to for the entire population, and then for women stratified by hotspots. And we found that both individual and community level features actually contribute to different variance patterns between these two populations, again illuminating the importance of multi-level studies to investigate individual and community level data. And then, as I mentioned, you can see some of these health behavior patterns as well as access to care illustrated on the right now for the United States, where the highest prevalence of physical inactivity is actually located in the South, associated with somewhat this diabetes belt and potential increased disease burden here. And then this is a little bit misleading, but the best I could find, when you assess differences in quality of care combined for non-Hispanic Blacks, Hispanics, and Asians versus non-Hispanic whites, you really see gray being the worst differences in quality of care. You can really see some of that in the Appalachia region as well. And so all of this put together really drives home the point that our need to understand the impact of community health behaviors is critical to include in tailoring strategies to reduce disparities in early onset colorectal cancer. Again, it's kind of the social need versus social structural component, and instead of addressing something on an individual level that may not sufficiently address the structural issue at a population level.
Andrea, we have a couple quick questions in terms of what is the racial and ethnic distributions in the southern USA hotspots counties. Do you have that information?
Yeah, so it's a little challenge. I can answer it. It's a little challenging to answer. I can tell you for the women's study below, because I just submitted this revision yesterday. So I can tell you that among the U.S. southern region by census tract regions, accounts for 55% of the total Black population in the United States. And aligned with that, we actually see that proportions of non-Hispanic Black individuals in the population account for greater variance in survival among women residing in hotspots versus non-hotspot counties. And similarly, race as an individual level feature also accounts for more variance in survival patterns among hotspots versus non-hotspots. So there's a lot of overlap and interrelatedness in this, but specifically for women, when looking at adjusted models, for women, hotspots were not associated themselves with an increased hazard of death in adjusted models. However, race and ethnicity did pull out as an independent prognostic factor there, even after accounting for different county level features and whatnot.
Awesome.
So there'll be lots more data in the paper. It's a bulky paper with lots of data, but hopefully that starts to tease apart a little bit of the question there.
Right. I think it does. And I think to the spot about hotspots, and then we have one question about how quality of care was defined. And I'm sorry, I realized I cut you off in the conclusions. I thought we were moving to the next slide. So I was like, wait a minute. Sorry about that. So I do agree. This is absolutely fascinating from Gloria Coronado. Interested also, did you map the hotspots for hotspots for early age onset disease for men as well?
So we did not. So in the first study here, these are for men and women. And given that subsequent linkage, the goal of that paper was to solely focus on men. We wanted to focus on women, but I agree that it would be really interesting to see how these tease apart. But I partly expect that given the increased hazard of death among men versus women in early onset survival, that the hotspot patterns for men would more closely parallel this top figure than they necessarily would the bottom.
Okay, and then one other question for framing, how is quality of care defined in the study?
So in this figure on the bottom here is from the AHRQ. So this is not data from my study. This is just supportive data here. In terms of our study, because of the wide range in study period and SEER not having individual insurance status available till 2007, we looked at the proportion of individuals with a household income of less than $20,000 as a proxy for socioeconomic status there. There are also other community level features like the number of PCPs per a certain population, as well as some limited access to healthy foods, etc. But in terms of quality of care, I think percent uninsured was included in our study, and the household income factor are most closely related. Andy, are we good to move on, you think?
I am double checking. We are good to go.
Perfect. Okay, so as I said, much of this work's been done in the United States, and I thought this was really an interesting opportunity to present some international data as well, to further emphasize this global epidemic, but also because the findings were really striking and interesting to us as we got further into this study. So with a very close colleague of mine in Zaria, Nigeria, we decided to take upon a study to describe the burden of early onset disease among rural Nigerians. And I've mapped, I provided the map of Nigeria here to demonstrate that Zaria is in the Kaduna state in the north region of the country. Given that in the literature that's coming out, there are different patterns by geographical areas for other tumor types. It's really important to note that, as may be expected in this low resource country, that there are currently no organized colorectal cancer screening programs. I'm sorry, this says in Indonesia, it should say in Nigeria, although that fact is true for both. So looking at about a 28-year study period for a individual cancer hospital registry, we identified 379 patients diagnosed with early onset colorectal cancer. And I just want to draw your attention to a couple of the interesting clinical demographic points related to the study population. The mean age at diagnosis, compared with data in the United States where it's in the 40s, here is 34.8 years. You see a high proportion, almost 60% of cases diagnosed with early onset CRC in Nigeria are male. And we see this remarkable left-sided shift in tumor site where 3 out of every 4 early onset colorectal cancer cases are diagnosed with rectal tumors. So when we took a look at this, we wanted to actually compare and address the disparities question a little bit and compare data on rural Nigerian cases diagnosed with early onset colorectal cancer together with African American cases using SEER data initially. And so what you see here are just really simple plots of the proportion of individuals by age at disease onset for each of the populations, where you certainly see that median age at diagnosis is going to be in the 40s among African American cases. But as I already kind of spoiled, you see this median age at diagnosis in the mid-30s among Nigerians. I do want to fully disclose and acknowledge that the shift is most likely largely attributable to the differences in population age structure between the two countries, where in comparison to 70% of the United States population being aged younger than 54 years, over 90% of the Nigerian population is actually diagnosed age younger than 50 years. I hesitate giving this number of 70.3% because it's really just combined for the entire United States. And that does differ by race and ethnicity across the country. But I think it strikes home the point here in that there's differences in age structure for early onset cases between Nigeria and the United States are largely attributable to this discrepancy. But we went on and were interested in comparing some limited clinical demographic features and initial analyses to see how early onset colorectal cancer may differ in Nigerian versus African American cases. And as expected and kind of very much highlighted already by me, you see this decreased age. It's Nigerians were more likely to be diagnosed at younger ages, and very strikingly, but not surprising in looking at the proportion of Nigerians with early onset colorectal cancer by site, we saw that young Nigerians were 8-fold more likely to be diagnosed with rectal tumors compared to young African Americans in the United States, and warrants much additional study. Overall, 2/3 of the Nigerian population with colorectal cancer is diagnosed with early onset versus 1 out of every 8 African Americans in the United States. And reflective of what we saw in our study in Zaria, there are reports of this potential left-sided colorectal cancer shift in sub-Saharan Africa. And we, as I mentioned, we saw that propensity of presenting with rectal tumors. And there have been published studies on signs and symptoms among patients with early onset colorectal cancer in the United States that affirm that indeed rectal tumors are more likely to be present symptomatic versus colon tumors. But the real question here in our ongoing molecular studies in this space is really to discern etiologies underlying this distinct colorectal cancer presentation, whether it's fully attributable to limited resources, lack of screening, etc., whether there is a distinct tumor biology, as well as acknowledging and accounting for patient beliefs, given that Nigerian culture also lends upon traditional healers when presenting with some symptoms that may be associated with colorectal cancer as well. Overall, I think it goes without saying that there's a need to implement organized colorectal cancer screening programs in Nigeria, and literature suggests that this is becoming an emerging priority in this country overall.
So wrapping this section up, a question from Dr. Wally from NCI. And Adriana, I don't think we covered this, but do we see rectosigmoid early age onset colorectal cancer seen among Nigerians reflected amongst our African-American populations in the US?
I didn't present that data here. This odds ratio where young Nigerians are 8-fold more likely to present, you see a much lower proportion of non-Hispanic Blacks in this study here be diagnosed with rectal tumors compared to Nigerians. I don't want to come out with a number because I don't remember that exact number. Hopefully this paper is on its near way to acceptance, but you'll be able to see then that data shortly, but I'm happy to follow up with that. But I do know it's a markedly lower proportion of early onset tumors in non-Hispanic Blacks that have rectosigmoid junction and rectal tumors.
Okay. One other question here, and I think there might be one in the other panel. I'll look real quick. In countries with non-Western lifestyles, do you think it's possible that email just popped. Preponderance of early age onset may be because the cancers are more commonly driven by germline mutations, i.e. Lynch syndrome?
Yeah, that's a really interesting question. When we conducted this study and found these findings and started looking into the kind of the presentation of colorectal polyps in this population versus the prevalence of polyps among patients with colorectal cancer in the United States, we became really interested in exploring whether there may be a founder mutation in the Nigerian population associated with early onset colorectal cancer. In this case, we're currently in the process, a bit delayed with COVID, but of being shipped a couple hundred Nigerian tumor blocks and normal blocks to begin undertaking some of these molecular studies between rural Nigerians and African Americans in Nashville. So these are all great questions and really forthcoming, and not to give a spoiler alert, but I think on the exact point that someone mentioned regarding Western lifestyles, you'll see some interesting findings from the Indonesia study shortly as well.
Good deal. And one other question before we move on, and I think to the framing of Dr. Wally's question, I think Philomé had a question in the study that you referenced, were the African Americans of Nigerian descent?
In this study right here that we just conducted, I actually can't, I don't know. So we leveraged SEER data at this initial point, partly due to COVID, and we really wanted to be able to do a population-based comparison in the United States. So in SEER, the individuals reported as self-reported as African American or non-Hispanic Black, and that's the only data we had on race or ethnicity. We don't know whether these individuals in the United States are of Nigerian descent, and is indeed a limitation of the study, but something that we hope to better address in future work.
Great. I think that, let me just make sure. Okay, yep, that hit it. So
Perfect.
I think we're good.
Okay, so I'm briefly, I leave most of this to Jose, because he's the expert on early onset, particularly in Spain, but he graciously let me steal the spotlight for a second to briefly describe some of the early onset colorectal cancer burden in Spain. And so in a study that we've worked on to examine prognostic factors of microsatellite stable colorectal cancer in young Spanish patients, I'm just illustrating to you here the study population of early onset cases with MSS. CRC in Madrid, Spain, to kind of illuminate some of the unique characteristics of early onset CRC in Spain, where 54% of cases are male, and 41% of cases are diagnosed with tumors in the rectum-rectosigmoid junction. But the really interesting data available through this cohort study was the information on history of colorectal cancer, or history of colorectal polyps, my apologies. Where taking a look at this data, you can see that nearly half of patients diagnosed with microsatellite stable colorectal cancer before age 50 actually had a positive history of colorectal cancer polyps. And moreover, even beyond that, 92% of these cases that presented with polyps actually presented with at least one after colorectal cancer diagnosis. So among these yes columns, these groups are not mutually exclusive, but you can see that nearly all cases with this history of colorectal polyps continued to present with polyps after diagnosis, I think even beyond the routine 5-year surveillance period. And so in ascertaining the potential prognostic factors of early onset CRC in this cohort, we wanted to take a look and stratify by patients diagnosed with polyps after diagnosis versus not. And indeed, patients who presented with polyps after diagnosis had significantly improved survival versus cases without polyps. And they were associated with up to an 80% reduced hazard of colorectal cancer-specific death in adjusted models. And I really wanted to bring this up as the highlight from this study in Spain, because I think it really lends to emphasizing not only the diversity of polyps across different populations with early onset and geographically, there's real importance on a comprehensive characterization of colorectal cancer polyps among patients with early onset CRC, both clinical and molecular features. I think there's a real need to better understand the prevalence of polyps, especially across some of these racial and ethnic population subgroups as well. So this was obviously meant to just be a brief overview and a little bit more to describe some of the early onset features in the Spanish population, but I think also drives an important message at this point. So lastly, and I'll be briefly because this data remains unpublished, I just want to highlight and kind of be able to compare some Western countries versus the non-Western world, and our initial collaborations ongoing to describe the burden of early onset colorectal cancer in Indonesia. And so just to kind of give some background data here, Indonesia being comprised of over 14,000 islands, our collaborations are with an ongoing prospective cohort study on the island of Sulawesi in the southern region of the island. And what we actually find from data from this cohort study is that 1/3 of all Indonesians with colorectal cancer are diagnosed with early onset disease. So not as dramatic a shift as 6 out of every 10 Nigerians diagnosed with early onset colorectal cancer among all CRC cases, but not as low of a frequency as about 1 in every 10 colorectal cancer cases being early onset in the United States. And to kind of, again, put this in context and proportion, 83% of Indonesia's population is younger than age 54 years. That's in contrast to the 92% of Nigerian population and 70% of United States population. So this number may also be attributable to some of that population age structure. Similarly, there are no current organized colorectal cancer screening programs in Nigeria, but very interestingly, in the entire country, data reported from the CIA World Factbook, less than 7% of the adult population in Indonesia is actually obese. So I think our examination that's ongoing of clinical demographic as well as dietary patterns of early onset versus late onset patients with colorectal cancer will be very interesting to understand how some of these different individual health behaviors may uniquely be attributed to early onset disease, not in the Western world. And I think this study is really the clincher overall, and kind of the data I presented to really describe the snippets of the early onset colorectal cancer burden worldwide, but really highlight the differences across countries and populations that we really need to better understand whether some of these phenotypes differ, whether it's outcomes or certainly molecular features, but to better understand whether the rising disease burden of early onset colorectal cancer is consistent across different countries, or whether there are distinct patterns of disease. So as I've mentioned throughout the course of this talk, 1/10 of all colorectal cancer cases in the United States approximately are early onset. Approximately 37% of patients diagnosed with early onset CRC in the United States are diagnosed with rectal tumors, and the early onset population is comprised with 53.4% being males. In Spain, you see pretty similar statistics here, with about 2 to 8% of colorectal cancer cases being early onset. 4/10 of all tumors being diagnosed in the rectum, and very similar patterns for the proportion of the population that is male. Kind of taking a shift, as I mentioned, 3/10 of the Indonesian population with colorectal cancer is diagnosed with early onset disease. You see this upward tick now that closer to 50% of the population is diagnosed with rectal tumors. However, by sex, you see that the population is only comprised, 43% of it is male. So you have more women diagnosed with colorectal cancer at early ages in Indonesia. And then really setting that next to the Nigerian statistics, where 2/3 of Nigerian cases with colorectal cancer are early onset. See this real left shift in tumors, where 3/4 of cases are diagnosed with rectal tumors, and nearly 60% of all cases here are male. So I think this really highlights the differences and the breadth of the early onset colorectal cancer burden geographically, and really the importance of beginning to understand this epidemic on a global scale, but also across countries and different subpopulations. And so really just kind of some thoughts on future early onset research directions. I do think, and we are starting to work on this, and that in additional multi-omic studies of early onset sporadic disease across and within diverse population subgroups are needed overall. And multi-level research on these dynamic relationships between individual level features, the macro environment influence, and health disparities are needed in early onset colorectal cancer. Kind of carrying it from the clinic to the lab, as my research program is actually half lab-based, there's a real need for laboratory-based studies to begin elucidating some of the mechanisms that underlie disparities in early onset colorectal cancer. And I haven't mentioned much of this in the talk at all, but I wanted to acknowledge this as a need for a future direction, and that we really need to understand potentially unique survivorship needs and how these may differ among young patients with colorectal cancer by population subgroups, whether that's population density in rural versus urban regions, by race and ethnicity, sex, etc. I think we need to take a personalized approach in understanding what patients really need to not just survive, but survive and thrive after an early onset colorectal cancer diagnosis. And lastly, I think there's these data amassed to really suggest that we need a large-scale international investigation of early onset colorectal cancer to decipher potential phenotypic differences in this disease burden worldwide. And I bolded this one because I think it's a little bit of a spoiler alert to be able to kind of announce that Dr. Perea and I have really launched this initiative to begin moving in that direction with the GeoCode Consortium, or the Global Early Onset Colorectal Cancer Database. Geocode is right now comprised and represents over 10% of all countries worldwide, with representation across 5 continents and over 45 institutions participating in this cohort, with the overarching goal to decipher geographic variations in phenotypes and potentially outcomes of early onset colorectal cancer worldwide, and really tease apart many of these disparities, whether it's by sex, racial and ethnic subgroups, as well as geography, given their interrelatedness. I think that Geocode is moving in the right direction to really be able to take large steps in unraveling and eliminating these disparities. Of course, all of the work that I talked about could not have been done without a huge team, including my lab and team at Vanderbilt, together with a plethora of colleagues worldwide, highlighting ones in particular who've contributed to the studies that I've presented throughout my talk today, as well as a plethora of different funding sources. For me, my work in early onset colorectal cancer started as a graduate student in the early onset disparities and survival piece by race and ethnicity. And so it's a passion that grew there that now my research program at Vanderbilt is able to really delve into and hopefully make a positive impact in reducing the burden of colorectal cancer in young patients. But I'm really grateful for all of these collaborators and their multidisciplinary expertise to really be able to do the breadth of diverse studies that you see me present here today, as well as our other ongoing work. And so with that said, I'm thrilled to take any additional questions. I think already I actually really appreciate going through them when we're on the topic, given how much we've shifted across the breadth of disparity space in early onset colorectal cancer. But we would be thrilled to also develop new collaborations within the work group and with others that are on the call. And with that, I am happy to take any questions and kind of lend into hopefully a great discussion.
Great. So Andriana, we are going to have a few more questions rounding out this last section. We'll have Dr. Preya join us as a keynote discussant and some response to the great work as well. And I know Dr. Preya, as a leader in the field, has been also sharing some perspective as we go. Fantastic work. I would definitely agree from Samir. I think there was a question from Anil. How does the data among Spanish population that's reflected in Europe, how does the data among Spanish population is reflected in European Union countries? Are there differences in early age onset stratification versus early age onset disease among Europeans? And Anil, I might have you come off mute. I know sometimes it's hard to type in chat to make sure that we get the zest of what the question is. Anil, are you able to come off mute real quick and ask? I know you had a couple questions.
Yes, can you hear me?
Yes, we're going to punt to you to ask real time. And then
Fabulous presentation. Couldn't have been done any better. I am just really awesome presentation.
Thank
to
you.
both Jose and Adriana. It's unbelievable. So it was so clearly mentioned about all the aspects of the disease for a lung cancer mesothelioma guy like me. So I'm really fascinated by the data I'm seeing. So coming from the Cancer Health Disparities Center at the NCI, so we are very much interested in knowing the stratification of the disease, because we usually have a tendency to clump and cluster all different races, ethnicity into one group. Like Asians can be also stratified in Southeast and Northeast, and same happens true with the Hispanic Latino populations, as you nicely described, among Mexican, Puerto Ricans, and Cuban populations. So same thing applies to the African nation as well. So that was, I was interested in that as well, because as Africa is composed of more than 30 countries. So at the diaspora, that is in USA, is basically reflected from both East and West African countries. So that's why we are interested in having stratified data based on race and ethnic populations. So you have alluded nicely all the data. So while you were mentioning about the Spanish data, so I was just keen to find out whether does it hold true for other European nations, Italy, Germany, France, so on and so forth. Maybe you don't have collaboration at this stage, but it would be worthwhile to figure that out. Thank you.
Yeah, great. Thank you for your kind comments and for your great questions. I'll answer, but I also think Jose, being the expert in Spain, can also touch upon points that I may miss. I think your point is one that's well recognized. I know Jose is going to show a figure of early onset incidence worldwide and how that differs. And we really see some discordant patterns across Europe in early onset colorectal cancer incidence, where in some countries you see a sharp rise and increase versus some countries remain stable with their early onset disease burden, and some are actually seeing a decline. So I think there is heterogeneity within Europe that warrants further exploration as well. I think that's one of the great facets of geocode, and having a plethora of European countries participating. The map that I actually had that represented geocode highlighted all the countries that were already involved in this initial effort. But one of the great things that will derive from this robust data source representative of multiple institutions across the United States with in all different regions together with Europe is the secondary analyses that may derive in being able to look at these patterns by sex or ethnic groups within a continent, within a country, worldwide. And so I think it's really creating a robust resource for secondary analyses in that way, because I agree, as some of the data emerges in small studies to show racial and ethnic differences in molecular features among colorectal cancer patients overall, given the challenge to do this specifically in young patient populations. I think that's going to be a really important question in translating this work into prevention, intervention, and potential therapeutic strategies. But Jose, maybe you have something else to add?
Yeah, I agree with Andreana. That was the aim of creating geocode. The first strategy was only to collect countries from around Europe, just to compare all the phenotypes regarding or comparing countries, and comparing also different areas from the continent, because if you know, in some points Europe is very different comparing Northern Europe and Southern Europe. So we are making all the comparisons within continents, and of course between continents. And the first approach, because now geocode has data from Europe and from Latin America already, and we are going to compare all the data within the continent just to see if there are different phenotypes within comparing the countries. Yeah, that is the main idea of the study. So Andy, if you want...
Sorry about that. Samir, let me just ask before we move in. Samir, I know you had a couple questions, and I think you and Jose had some discussion. Samir, is there anything you'd like to come off mute to follow up from the last section?
No, I think all my questions got answered. I appreciate it.
Okay. There was a quick question. There was a question about just following the thread about how finding polyps meant less risk of death. I can look up the study if there is no time. So I don't know if that's specific. I think the adenoma sequence was the polyp generation slide was mentioned. Is that, Andrea, is that coming, any specific response that you're seeing?
Maybe Jose can answer a little bit more on the clinical side of things. That study's not published yet. And so we are happy to share it once it once it's released with the work. But in terms of polyps, I think it is also regards to surveillance and follow-up as well that may play some role there. But Jose?
Yeah, maybe we should take on account two points. For example, Samir has pointed out one interesting question, and I'm going to show the article that they have published a few months ago, that there are so few studies regarding adenomas in young population that this is a very important gap to take on account. That is one point, because I think we should study if they are previous lesions to the colorectal cancer. I think that no, but we should take on account, because in our study that is now under review, we have seen that almost half of the cases with early onset colorectal cancer has not any polyps during the follow-up. We have been following up those cases for at least 10 years from the diagnosis and before. So that is a very important point. And then another point that Adriana has addressed, very interesting, is that early onset colorectal cancer without any polyps during the follow-up, I mean previously and later on, has got worse prognosis compared with those cases that has been associated with polyps during the follow-up, having the same follow-up all of the cases. I mean, this is no difference, and then because there will be a bias in that direction. So those points, and I think the role of polyps within early onset colorectal cancer population is very interesting, just to develop if they are previous lesions to the colon cancer or not.
Okay, excellent. So Jose, we're going to go ahead and punt to you, I think, for follow-up and helping frame up some of the discussion moving ahead.
Yeah, I try to be a little faster. So before moving forward and address the questions of the people, I would like to remark some of the aspects pointed out by Adriana before starting the discussion. So first of all, in these few slides, this is one interesting map that I present in most of the talks that I give, specifically about the incidence of early onset colorectal cancer worldwide. If you see the map, the increasing incidence in early onset colorectal cancer is different if you compare some continents and some countries. In red color are the countries that has the higher increase in incidence in early onset colorectal cancer in the last years. Then you will see differences regarding the color. Then yellow are the countries that has got higher incidence, but not so high as red ones. And then in green color are the countries that in the studies, I mean in the registers that the study has published, has got no increasing or almost a decrease in the incidence of early onset colorectal cancer. So I think this is a very important point, just to take on account if we focused on disparities regarding geographical areas about early onset colorectal cancer. Next slide, we will see another interesting point, that is difference regarding gender and age of onset. This is a study that we have developed here in Spain. We analyze the colorectal cancer-related death risk according to age intervals and sex. This first figure represents the comparison between age intervals, and you see in the maps, in the areas, the red areas are the areas that has got high risk death related with colorectal cancer, and in green are the areas that has got low risk. So if you can see, if you compare ages between 54 or less, then the ages between 55 and 74, and then older than 75 years old are completely different, the distribution of the risk. Then in the next slide, you compare not only the intervals of age that is in the above figure, but also we analyze the colorectal cancer related death according with differences in gender. So in the figure below, you see specifically the death-related risk for men. So if you can see, are more or less comparatively equal if we compare with the group together with female, but maybe some remarkable risk, more remarkable risk for male people. And in the next slide, if you compare female, you see that are completely different those cases with globally compared with the groups that has been pointed out with females. So the distributions in the comparison between gender, between ages are completely different regarding geographical locations here in Spain. And in the final figure, you see the comparative analysis between male deaths and female deaths. So if you can see, the risks are completely different. And again, as Adriana has told in the talk, for males here in Spain is also there are more risks related with deaths, and specifically in early onset colorectal cancer are very, very interesting areas concentrated in 2 points of Spain that hopefully in our future articles we are going to develop why this is, what is the reason for these differences. And finally, in the next slide, just to underline the importance of our study, Adriana has already introduced in her presentation this study. Here we think that here is the one of the possible efforts we are developing to understand the disparities exposed. So we are still open to new countries. As you can see, we have countries from most of the countries. Africa is still lacking, but we have countries for all the continents, and now it's active to be enrolled from all countries around the world, different centers. So you are invited to be there. And then if you want, or if you have questions, then we can move forward for the discussion.
Jose, thank you a ton. And I think Rick Boland had a great question. Back to the questions about the Spanish, looking at the data, did the demographics for early age onset patterns carry over to Portugal? Do you know?
So this is a very interesting data. I have already the data, and as always, Rick has the interesting questions about the issue. So if you see in this slide, you don't move it. You see specifically for early onset colorectal cancer, not for the other age intervals. You see that in Spain, in northwest of Spain is Galicia. That is a region specifically in Spain. And then in Portugal, we are developing the same study because in the National Institute of Epidemiology that are developing these maps have got also the data from Portugal. And again, it repeats for early onset colorectal cancer, the death-related risk for the north of Portugal is the same as Galicia. So that is very interesting point regarding this disparity and this concentration of risk regarding the age intervals of population.
Okay, great. And I would echo Anil's point about great geocode consortium being developed. And I do think Adriana and Jose, I know that we've had some discussions with different collaborators in the US, and of course you have folks abroad, maybe in one of the upcoming opportunities, or maybe even an opportunity that we could host is also digging into what that consortium is really about and how to join in is something that we can continue on as well. So this is something that Fight CRC is very much interested in helping support. So that's something we can help continue. And I think there's probably people around the virtual table today that are pretty excited about this work. So a huge thanks. We're gonna go ahead to addressing some of the pre-questions that came in, because we do want to give some time for these pieces. And I know Jose and Adriana both had the questions ahead of time and tried to in their discussions also kind of head off some of the, or actually address some of the pieces so that we can get into some of the question further. So I'm going to go ahead and kick it off to both. I'm going to open it up to Adriana and Jose, and you guys can decide what order you would like to respond. But the first question is that survival, or the statement in question is survival and outcomes in early age onset colorectal cancer, in terms of thinking about the disparities between subgroups in the or in the population, and also how outcomes compare to late onset CRC. There's a question about those survival outcomes overall, I think, for early age onset population. And I think that part of that question was hoping to get out, what do we know about the statistics of people who are maybe not considered early age or probably over 50 for our purposes. I think that's where we were going with that. Adriana, do you want to share some perspective?
Yeah, if I can just really quickly address one question left in the chat about the comment for a similar geographical distribution map in all of Nigeria. Is related to the outcomes. I think that's really interesting. We have begun to try and also look at things with outcomes as we are doing a lot of molecular profiling with the Nigerian and African American tumors. However, it's extraordinarily challenging to ascertain outcomes data in Nigeria, in Indonesia, and some of these countries is very individual institutionally specific. And has a lot of challenges in accurate data and issues with access to care and patients who actually follow through with their care at the Nigerian hospital versus choose to forego care due to financial toxicity. So unfortunately, I don't think we're fully there yet. I think some of the large-scale country data, per my understanding with my Nigerian colleagues, is the best that they can do, but incomplete. So I think there's a lot of work there. But to actually answer your question, Andy, I think I showed in the beginning of the talk that outcomes among early onset colorectal cancer cases are poor compared with late onset cases, which, as noted, having young patients be more likely to be diagnosed with later stage disease and with these adverse histological subtypes that confer poor survival is concordant. In terms of overall survival numbers, comparing the entire populations of early versus late onset, being a disparities person, I tend to dissuade from that. I can tell you in our study, overall survival among young Blacks was 68.1% for colon and rectal tumors together. It was 55% for non-Hispanic Blacks. And it was 63% for Hispanics. To kind of frame that, overall survival numbers for all patients is about 64% in colon and 67% in rectum. So you really see this heterogeneity, but it's lending towards early onset having more aggressive disease.
So, and another question that came up for data is thinking about longer term survival, or at least 5-year survival for early age onset, those that are diagnosed. What are the survival rates? And I know that was one of our questions. So hinging on this data piece around survival, anything specific in response, Adriana?
No, I think ascertaining and understanding long-term survival is an ongoing question. I think that's a bit more readily done at single institutions that are able to follow patients over long periods of time. However, given the shifts in incidence and these patterns where early onset colorectal cancer has been gradually increasing, gathering the right population of patients that fall within that window for long-term data may not be as mature as we would like yet, but perhaps comparing across smaller time periods for early onset would be more feasible in a real long-term scenario. But I do think there are a lot of factors that need to be taken into account when it comes to long-term survival and other competing factors and hazards of death there.
Okay, great. And I do want to pick up on one thing that you had mentioned, about looking at survivorship research and the younger population of colorectal cancer survivors. I know Yin Kao, I think, is on the line, and several others have actually mentioned this in an area for further exploration. I do hope that through this series, we can actually have more dedicated discussion. And I know even when we were together in Spain, Jose had some dedicated time in this area. And so I think we should really grow this area around really looking at survivorship moving ahead. So I just wanted to make that plan that I know that we'll be looking at the series coming forward up until, even the next year. So we have 6 or 7 opportunities to gather. So that's an area that I hope that we can look at is overall survivorship components. Andrea, the other question here, we have 2 more. The first being is that epidemiologic results of the investigations of population at risk and the use of markers as a diagnostic factor. Do you want to share some perspective on those components?
Yeah, in terms of markers as prognostic factors, given the marked disparities, I think we need to understand more the etiologies and identify potential prognostic factors that may be worthy metrics in addition to some of the clinical pathologic features that serve to be prognostic. I really think this is a large undertaking, and we, and I'm sure others, are looking at molecular features by race and ethnicity among young patients at the moment to really understand whether identification of a prognostic marker in this larger population, I think, as was a comment made by Anil, is it really applicable to the entire population given this heterogeneity across racial and ethnic groups by sex and whatnot? So I think when we are able to have one, of course you want to use it and implement it, but then gearing towards that personalized approach, the ability to optimize some of this for subpopulations would be ideal.
Great. And then the last one targeted, I think, at the presenters today is if you know of specific databases and what does the speaker know of specific databases for early age onset disease and what type of clinical metadata is collected, i.e. Antibiotic use? And
Oops, sorry. I think geocode is a great example of that, largely because given that early onset colorectal cancer accounts for about 10% of cases, doing single institutional work can be challenging to have enough statistical power to begin to look at molecular differences and even some of these health behaviors that are mentioned with antibiotic use. I think geocode seeks to respond to that need as we're collecting some detailed information on health behaviors at the individual level, as well as hopefully being able to integrate some community level data in addition to looking at molecular features as a long-term goal and outcomes.
Great. And so I want to just quickly address some of the other general comments that came through, and then we'll open it up for a few additional thoughts and questions. I know we've actually been doing that real time, which I think has been great. So I think if there's anyone else who has other pressing questions, ideas, or thoughts, if you can put those in the chat, we're happy to have you come off mute for a few minutes. We've really, I think, covered a lot of territory and heard from a lot of folks. There was a question if there were a list of research projects that currently need funding. So all of the funders out there, I do think what Fight CRC is really aiming to do is through this opportunity to further build out platforms and connections where we will connect people for research collaborations, talking about shared ideas and vision for research studies and proposals. I'm thinking there's probably any number of people that would be happy to help share what are some of the projects that are coming forward. So I would say that that's something that we are hoping to definitely pull together opportunities for building collaborative projects, common themes and ideas. I know, and I want to also just make or do a shout out to NCI, who's hosting the think tank meeting September 24th and 25th, where they're also really hoping to engage research collaboration. We're going to hopefully learn from that opportunity to build into this series moving ahead. So there's a lot of opportunities, I think, to share and grow. So if you have those ideas, we will look at coordinated ways to pull that together to share kind of some of the ideas that are bubbling up. I know the provocative research questions from several of our funders and all, that's something we'll try to highlight at these calls, or what are the funding mechanisms. I'll just do a quick note that Fight CRC, with the help of NCI and DoD, have a list of what those funding mechanisms and proposals were up to about 6 months ago. We will be updating that and sharing that with the group with help from our partners moving ahead. So that's something I can share as well. The other question that we got was also from a dissemination and implementation approach, and how do we foster? I think number one, I think if there's research opportunities, sharing those, learning the insights, topic areas, thinking about collaboration is a good way. Fight CRC has created a subcommittee under the direction of Samir Gupta and Josh Dem that are looking at quasi-D&I type projects where we're looking at thinking about management of symptomatology. What do we know about how in the study of how people are presenting with signs and symptoms? There's concerted effort in some specific areas with the work group we've created to do work specifically in some of these areas. So if you're interested in these types of approaches from a D&I standpoint, please do check in. Would love to get some more energy on these types of proposals moving ahead, again, with that funding piece. And I think that question about does the speaker know of databases or repository, for those of you who either heard of the meeting in Denver in February of 2019 or attended, one of the things we aim to gather are what are current databases, data opportunities, even how do we look at ascertaining tissue and blood and the like, and how do we really look at opportunities to use what's been developed for research moving ahead. We still have a list of those that were established at that time. That's again another thing that we hope to continue to convene some discussion about what opportunities there are for shared resources, consortiums, collaboratives, longitudinal type approaches, other types of cohort studies that we might be able to work in tandem. Those are the things that we're hoping to work forward in terms of continuing to update that as well. I'll have Reese and Elsa send information about where to actually ascertain and to gather that information based on what we've collected. And I think there was a question about what are the current screening modalities to manage early age onset colorectal cancer and disparities. And what I want to say is, I think for average risk population, the American Cancer Society and the USPSTF guideline folks have talked about, the different types and the different modalities for invasive, non-invasive testing. But I think one of the things I want to just really highlight is that people who are at high risk or symptomatic, we know that colonoscopy is still the recommended. So for people who are very young, oftentimes presenting with signs and symptoms, the non-invasive FIT and FOBT or stool DNA or even the other types of tests are not recommended at this time. So I do think that that's a really good comment about how do we use CT colonography, how do we use FIT and FOBT testing. I think in light of the need for really looking at all screening modalities to address, that's something that we should consider. All the screening modalities, the best screening test is the one that gets done and gets done well. But I do think for the high risk population, we have to also just know that the recommended guidelines do really still point to colonoscopy. So those were the comments that came in. We wanted to give a good nod and time for those. I am going to go ahead and just look and see right now. There is a question that says, as vitamin D deficiency is widespread among African Americans, are any studies looking at that, especially as it's found to be related to CRC diagnosis? And since vitamin D allele were found to be important in the FIRE3 study, and this might be relevant to the Southeast population as well. So anything specifically, Andrena, that's coming up?
Not to my knowledge. I think this is a really compelling point and warrants some additional inquiry to consider, as both work in Indonesia and Nigeria is ultimately seek, as well as other international collaborations, is seeking to do some wide-scale multi-omic profiling to better understand the molecular features of disease. And so if that there's an opportunity to investigate that, I will certainly look into it, but I really appreciate that.
Great, thank you, Annie, for your comment. Laura, I might have you come off mute, and because I think you have a Laura Werley, I don't know that we've met, but thanks for joining today. Laura, do you want to come off mute? I don't know if you can, but I'll go ahead and read the question if she's not able. Do any of the research results warrant a change in screening age recommendations or the addition of young onset CRC to public awareness campaigns and education of physicians, especially primary care docs? It seems that the ultimate value of the research would be applying it in such a diagnosis at early age or early stage can be achieved in these young people as had been done for those over 50, and thus greatly increased survival rates, saving young lives. Thank you for doing this research and a great webinar and being so inclusive.
I think that's a great comment. I really appreciate the question. I don't want to be premature and say that there should be a change in screening age recommendations, because I think some of this work is really just the tip of the iceberg that we're starting to delve into. I very much think that the addition of early onset CRC to public awareness campaigns, in addition, and education of general practitioners is really important. I think on Twitter, since the tragic death of Chadwick Boseman, one of the things that has emerged is many colorectal cancer survivors and thrivers at young ages have shared their story. And albeit really hard to swallow, many of them say that they were misdiagnosed or that their symptoms were ignored. So I think there is room for improvement in the short term here to really raise awareness, which is something that I think Fight CRC is incredible at doing and is a champion in this space. And continue reaching out to really, I think, address the stigma associated with it, as Andy mentioned before, and then ultimately be able to translate these findings sorry, that just disappeared, and be able to translate these findings and really diagnose patients at earlier stages, because I think that will mitigate the difference that we're seeing in prognostic outcomes to some extent between early and late onset patients. Because ability to detect earlier is, of course, going to save lives versus detecting aggressive late-stage disease. And so, yeah, I think those are all really important points overall.
And I want to make a nod to Whitney's comment about the DNI, and even what we're doing, what we're talking about here is really a point for opportunity to moving ahead. And even with the current guidelines, there's so much to be done. They could either be studied or, quite honestly, just implemented in better practice. For real implementation, I think, to an earlier question. So I'm going to go ahead and transition us, and I know I'm going to have
only two things regarding that comment, if possible. Can I?
Yes, go ahead, Jose.
Okay. Just to make a note. For example, I'm colorectal surgeon, so I think it's essential for all the people that are related with clinics. I mean, all the clinicians, all the doctors, all the nurses. That I think we should have in our mind the diagnosis of colon cancer in people with young onset, with young ages. Because if not, we can do whatever we want. We can make the best discoveries in the fields of research. But I think the first step is just to put in the mind of everybody that are in the first step for the patients to make it know that a bleeding is not only hemorrhoids, can be a rectal cancer. And of course, I think it's more important if we take on account that the most frequent locations for sporadic cases are rectal cancer. So I think that is an important point. And then maybe one of the steps that we should take on account, at least, for example, for trying to make screening strategies at least in countries that we don't have so much increase in incidences, is maybe try to find out population in risk. I mean, maybe we should screen some type of diabetes population that has maybe 20 years, 25 years. So those points I would like to remark, because I think they are important enough.
And I think that building on that really contributes in the disparities perspective to access to care, because whether it's a rural versus urban region or whether you have poor access to care, the widespread need for universal education among providers, so that even individuals that may have limited resources, if and when they present with symptoms, have the opportunity and access to care that similar individuals may have in other environments.
Okay, great. And Jose, we'll have you round us out with the connection to some of the research published and our information about the time coming up in Spain next summer.
Sure. So the idea of these webinars also is not only to have great talks about some specific items, but also we would like to make a review of the last papers, works that have been published related with early onset colorectal cancer. In this webinar, I have chosen two that I would like to read, and if people are interested in the articles, you have the references just to read more deeply in that direction. So this is the first one. This is a work that has been developed by groups from Sweden and from Germany. It has been published in American Journal of Gastroenterology, and the title or the item is just a personal history of diabetes as important as family history of colorectal cancer for risk of colorectal cancer. That is developed by a nationwide cohort study. So in this study, I think that the next slide, please, Luis. So I think I have chosen this article because I think this is the first one that linked diabetes in colorectal cancer, specifically in early onset colorectal cancer, in a population outside USA. So this is very important, again, to see which disparities are, which are not disparities. We have some points in common. We have differences regarding early onset colorectal cancer in different countries. So very fast, the aim was to analyze the association between colorectal cancer risk, specifically early onset colorectal cancer with diabetes, family history of colorectal cancer, and age at the diagnosis. So material and methods, just that is a nationwide cohort study, specifically in Sweden. All individuals was born after 1931, and then you have the core samples, as you can see, is a huge core samples. The period of follow-up are those years, and then in the next slide are shown the results. So I think the most important thing is that diabetes diagnosed before 50 years old has almost twofold increased risk for colorectal cancer before 50 years old versus 1.3-fold risk of colorectal cancer at or after age of 50 years old. So this is very interesting regarding early onset colorectal cancer. Also, diabetes diagnosis before 50 years old in those with a family history of colorectal cancer increase the risk. You can see in the slide with almost a six-fold risk of colorectal cancer before 50, compared with almost a two-fold risk of colorectal cancer at or after the age of 50. And finally, they put in the same level of risk diabetes and family history of colorectal cancer. But I have to underline that this is only a study specifically in one country, not in a general population. Finally, the conclusions. They develop a systematic review, and specifically the aim was a systematic review of young onset adenomas, prevalence, associated risk factors, and rate of metachronous advanced neoplasia after young onset adenomas diagnosis. The most important thing, if you see all the results, is that there are few studies analyzing this issue, and specifically, it is important to take on account that there is an important gap that exists in the direction of studying specifically adenomas in young onset population. So in conclusion, the next slide. So again, more research is needed to understand the prevalence, risk factors about this specifically population of risk of colorectal cancer associated with young onset adenomas. So these were the two papers. Andy?
Oh, sorry, Jose. I was actually speaking and on mute. So yeah, thank you so much. I think this is fantastic. We have, again, we're going to continue to follow this model moving ahead. Our next webinar will be in early November. We are looking at the topics that people had prioritized. We will be sending some connection and information about the next series that are coming forward. And I want to send a huge thank you for Jose and Adriana for the work today, the leadership, and all of the great pieces that we're moving ahead. And again, I think with Jose really helping us reach into Europe and the connections with other collaborators and countries, and then even the work that Adriana is doing, we're all just going to, I think, be stronger in these efforts together. So let's see, November 2nd is Election Day of the United States, you're right, or November 3rd. Maybe we should, I don't know what we'll do with that, but we'll go ahead and see. It could be an interesting day for sure. So we will go ahead and probably keep this date, but we will be sending more information. You should get a calendar invite. If for some reason you're not on our distribution list, let Reese or Elsa know. I know we're about 4 minutes over, but it's amazing because we still have 30 people on. So I just want to say a huge thank you for all of you for moving this ahead. More to come about how we're building these collaborative approaches. And I would give Adriana and Jose our final word.
Thank you, Fight CRC, for this amazing opportunity. I think, like I mentioned, there's a breadth of disparities. So much work has been done, and there's still so much to be done. I know I gave a high-level overview about a lot of things. I'm happy for people to reach out to discuss additional new efforts together, or any questions that they may have to clarify some of this work. So thank you again for this great opportunity and for the great work around early onset CRC.
Great. Have a good day, everyone. Thank you.
Thank you also for everything, for fight colorectal cancer, for organizing these webinar series. I think they are so important to keep to update the knowledge of early onset colorectal cancer. So we keep in touch, and of course, let's keep up the efforts about early onset colorectal cancer.
And Jose, people should mark their calendar for Spain. Yeah.
Hopefully, yeah. Now we are planning an in-person meeting, but let's see.
Yep. So we'll keep everybody up to date. Have a great day, and Jose, have a good evening.
Thank you.
Bye.